Myeloma today is very different than just 10 years ago. There are a multitude of options. It becomes very complex. I like to say it's no longer a sprint race, it's a marathon. We also like to say it's better to run 10-minute miles and finish the marathon rather than run 5-minute miles and have a good 5-mile time, but you don't finish the race. To prove that, my assistant made me run the marathon. I did 20-minute miles, though I didn't do 10. I didn't have such a good time, but I did finish. But in that regard, I'm a true believer that you need to take your time in many patients. And you need to think about the long-term goals here. You got to keep the patient in the race. You got to keep them well enough that they can avail themselves the opportunity of the newer drugs. And the newer drugs that are now in clinical development, they will be able to get, that may in fact be curative, and curative in a way that will allow them to live their life. Whereas if you beat on them, they may not be in a position to take them or tolerate them in a manner that will allow them to live their life. So I'm a firm believer that you can take it slow and you can take a breath. Now there are subgroups of patients you can't do that in. Those patients who come in with kidney failure, with lots of plasma cells in the blood, so-called plasma cell leukemia, terrible blood counts, people who got disease outside the bone marrow, so it's in the liver, the lung, that's bad. Then you got to go after it. But that's a minority of what we see. So I'm not a big believer in a big hammer. I'm a big believer that you need to be smarter. As my good friend Gio, who's on our board at the Institute, says, and he used to direct a lot of theater my wife was in, he'd say, it's not about more, it's about being more specific. And I think that not only applies to acting, it applies to take care of myeloma patients today.
Monoclonal antibodies in myeloma clearly are new. They're both daratumumab and elotuzumab were FDA approved in November of 2015, and I think we're still trying to understand how to integrate these into the therapy and into the treatment paradigms that exist now that we have many drugs. In terms of the MSMART criteria, the recommendations that are given is that they should be integrated at least after the second line of therapy. I would venture to say that in light of hopefully more positive data coming out from different clinical trials, including in the upfront setting, that these drugs will clearly in the near future move closer and closer to frontline therapy to sort of develop the equivalent of an R-CHOP approach that is currently existing in lymphomas in the myeloma setting.
One of the important questions that comes up now in clinical practice is sequencing strategies. And how do you sequence and how do you best or optimally use these drugs? It's important to really kind of understand where this question comes from. I think historically when we had limited therapeutic options, we would talk about using 3 drugs versus 2 drugs or saving options for patients down the road because we had limited therapeutic options. And that was an important concept, I think, historically in myeloma. But I think that's changed nowadays with our multiple therapeutic options that we have. And so I think it's important as you get all these different combinations, really as you try and understand how to best sequence them, let's come back to our core principles in oncology and help use that to guide how we use these combinations. So one of the core principles that we've seen now consistently is use your best drugs up front. We see this in myeloma, we've seen this in solid tumors, we've seen this in heme malignancies broadly. And that's use your best, most effective therapies up front. Don't save them for later. And I think that sometimes we get caught in that in myeloma because that's how we're used to thinking about it. Let me use drug A and then let me use drug B later because I think drug B can salvage drug A. And so even though I think drug B is a better drug, I'm going to save it for later or sequence it later down the road. And I think that's important to get away from that concept. Let's stick with our true oncologic principles that's well defined now over the last 50 years across all tumor types, which is use your best, most effective therapies up front. I think if you do that, I think that helps you understand sequencing. So when you start thinking about that, then I think it's important also to use your 3 drug combinations now earlier in the lines of therapy as well as in relapsed myeloma as well. I think that's important as well because now that's been consistently shown now across multiple phase 3 trials that 3 drugs is better than 2 drugs. And so I think that's the new standard of care as well. So I think if we stick with those 2 oncologic principles and principles that we've now learned, that becomes very helpful. As you start getting down into more of the details now, and for example, if you think about the aggressive or non-aggressive relapse, then I think it's very helpful then to start thinking about combinations as well in that setting as well. So for example, the phase 3 trial of Lendex plus elotuzumab becomes an important option for those patients with an early or indolent, non-aggressive relapse, or for older patients. Because really, when you look at the addition of elotuzumab and you look at the phase 3 studies, the difference in the side effects was really identical between the two arms. So essentially what you end up getting with, for example, elotuzumab is the addition of a third drug, the benefit of a third drug, the long-term disease control with an immunostimulatory component with minimal to no additional toxicity. So I think that becomes an important option where you get the benefit of a third drug without the quote-unquote cost or side effect of a third drug. And you get also, with the immunostimulatory component, long-term disease control as well. So for those patients with an indolent or an early relapse who don't need aggressive therapy to reverse their end organ damage right away, that might be an important option for those patients as well, of looking at that. And that's one example of how you would use sequencing strategies and identifying patients that may benefit from a combination